Okay, welcome to this session. Next session, the last session, I think, of today in this room. It's TAVI and Beyond, Tackling Coronary Challenges. So I have the honor of a great panel with Dr. Juan, Arif, Fadi Sawaya, we have Francesca, we have Verena, we have Nicholas van Michem, and we have Giuseppe Tarantini. So we have a lot of topics to cover, so we will have to keep a good pace in it. And let's bring the next slide. So the topics we want to cover here, or is there a clicker I can use? Let's see.
I can do it.
Yeah, here is a clicker. Yep. So there's a couple of objectives we want to tackle. That's first of all, and that's going to be the introduction, to understand why coronary access after TAVI is important. Is it important or is it really trivial? We want to learn what impacts coronary access after TAVI. I think Nicholas is going to talk about that. Also Fadi with Commissural alignment. We want to know how to appreciate valve design, implantation technique, native anatomy, because that's the three factors that play together. You have valve design, the implantation, how you implant it, and then the native anatomy of your patient. These three factors, they decide on the coronary accessibility, and then how to do it, also with some PCI techniques. And then lastly, related with the previous session, it's understand the impact of potential future TAV-in-TAV on coronary accessibility. So I think to go straight into the session, we want to, yeah, Francesca, you can show some case to show indeed the pitfalls of coronary access after TAVI.
So thank you very much for today's invitation. These are my disclosures. And I guess it's now Francesca's and my turn to catch you a little bit for the following discussion, presenting you some nice cases, I hope. But first of all, I'd like to give you some background information that will probably be more discussed in detail during this session. So we all know that the prevalence of coronary artery disease is very high among patients with aortic valve stenosis. We also know that coronary re-access can sometimes be a little bit challenging, especially using supraannular devices. And according to the re-access study, the success rates range between 60% and 80%, predominantly affecting the right coronary artery. And in this context, especially a very close THV to sinus relation, a very high implantation depth, and the use of an Evolute device were shown to be independent risk factors for a successful coronary re-access. And the case I'd like to present to you exactly fits into this setting. So according to the limited time, I won't mention all of the patient's details, but you need to know about three important points. First of all, an Evolute OR29 was implanted by our hospital several years ago in a more or less appropriate position given the previous recommendations on implantation depth. At least the implantation depth wasn't too high. Second, the patient already had a history of coronary two-vessel disease, also including previous PCI of the right coronary artery prior to TAVI. And finally, the patient was transferred by another hospital due to STEMI constellation and unsuccessful right coronary re-access. So as you can see here, the patient suffered severe ostial proximal and also mid-part stenosis, and there was no direct engagement of the coronary ostium with the guiding catheter, what remains the main story during this procedure. And this is one of the first pre-dilations, but even under using body wiring technique with a second wire, the suboptimal position of both wires didn't allow to proceed with large non-compliant balloons or even stents because they were always stuck somewhere between the guiding catheter, the ostial lesion, and the stent frame. So according to the worst backup I had, I lost everything repetitively, and I needed to restart again, this time optimizing the conditions a little bit, introducing a 7 French crossover sheet due to severe peripheral kinking or tortuosity, and also inserting a microcatheter. You can see the tip there, to make an exchange for stiffer guide wire deeper into the peripheral part of the coronary vessel. And from this time on, the procedure itself went more or less smoothly, implanting 2 stents in the proximal and then in the mid-part segment, followed by several post-dilatations to ensure the most appropriate stent apposition. And I guess that the final result is convincing given the initial circumstances. So before I will hand over to my colleague Francesca, I'd like to conclude the following points. Coronary re-access and intervention may be challenging depending on several risk factors. Specific tips and tricks can help to facilitate coronary re-access. However, the prolonged intervention times can also be associated with worse outcomes. So thank you very much for your attention. And Francesca, it's your turn.
Thank you very much.
Thank you, Verena, and thanks for all of you to be there with us. So I would like to share with you another case. A 16-year-old lady coming in our center in the previously treated by TAVI with a 26mm Evolut R and presenting in cardiogenic shock with the left bundle branch brush and ST elevation in AVR. So you see, the problem was that there was a left main obstruction due to a left coronary sinus sequestration. The previous valve was stuck between the TAVI and the aortic wall, causing obstruction and the cardiogenic shock. So we were, luckily, we were at 3 p.m. and not at 3 a.m., so several operators were present in the cath lab this day, and it was a really serious situation. So we put all the inotropic support and tried to engage the left coronary artery with several guiding catheter, and we could achieve just a non-selective injection with the mammary catheter, and we got a lot of trouble to go through the struts and to pass the struts with the wire and to wire the LAD. So finally we could success using a microcatheter and a Fielder XT, and through the microcatheter changing for a much more support guide and BHW, and could advance an extension catheter who couldn't go through the struts, but that anyway allows us to predilate the coronary ostium with several balloons with an increased diameter. The problem was that even if we could achieve a predilation with a 420 balloon, we couldn't achieve the stenting. So the DES couldn't truss the struts, the valve struts, even with the anchoring balloon in the distal LAD. And even if we could, we tried to push our guiding extension catheter through the wire and on the anchoring support. So finally, we tried to use several wires to go through the LID again and to have just support with the body wire. We couldn't, and the solution came from dual lumen microcatheter that couldn't just go on the first wire, and then allowed us to put another wire for a body wire, and finally allowed us to stent this coronary ostium and to reperfuse the left coronary artery with the detail that we could perform a sort of chimney in of course, post-valvular implantation, but with 2 stents because it was impossible to go through with a longer stent. So we were we had to put just 2 stents in overlap between them. So finally, after 3 hours of procedure, brainstorming of 3 operators, we could achieve success. The patient improved clinically and could recover an acceptable left ventricle ejection fraction in the following days. Thank you.
So yeah, I think Francesca, Verena, you really put the stage here. It's a real problem that can occur in clinics. Post-TAVI, having difficulty with coronary access. You already highlighted a couple of solutions with a lot of either support catheters, extension catheters, micro catheters, whatever solutions, but we come to talk about that later. But going a little bit back, not having the trouble yet. Nicolas, if you have your patient in front of you, you have to treat. What do you think, what impacts coronary access? Not only looking on the valve size, type you're going to implant, what other aspects do you consider?
Yeah, thank you, Ole. So very important question and a very important principle that we need to consider as we are thinking about lifetime management, right? We are treating younger and younger patients with coronary artery disease, so you will have a significant number of patients where you will need to re-access the coronaries. So I think this slide basically summarizes that there is a non-modifiable reality and a modifiable reality. So non-modifiable, obviously, we need to consider an anatomical reality. And if we go from top to bottom, then I think the important parts of this anatomical reality, and if I point here, you can see it on the screen, right? Haha, very good. So I think the first important anatomical landmark is the sinotubular junction. The smaller it gets, that will affect your valve platform selection because there is a minimum dimension of the sinotubular junction that is required for predominantly self-expanding systems. So for instance, if you have very small sinotubular junctions below 26 millimeter, then basically all the self-expanding systems are out of the equation because you need enough volume of these larger frames to expand. So that's one important part. Also, the smaller it gets, you can imagine that it also may become more difficult to get through a strut into a coronary if this is very tight. The second important anatomical landmark is the sinus itself. And in terms of sinuses, the most important aspect is the dimension. The wider the sinuses, the better it gets. I am very comfortable if the sinuses are wide. I'm not so much concerned about framework. I will get to that in a second. The third important part is the height of the coronaries. We all know low coronary heights, those are the difficult ones. Coronary height below 10 millimeters, that's a matter of concern. It's not impossible, but then it will definitely affect my valve platform selection. The fourth anatomical reality is the bulkiness of the leaflets. If you have very bulky leaflets that are very degenerated with these chunks of calcium, well, you can imagine that if you put in a valve in this degenerated leaflets, well, that you can then pivot the leaflets towards the coronary ostia, and that obviously might affect your ability to re-access the coronaries. So, and this is the anatomical part that you need to consider. And then there are also the modifiable, the easier things that you can affect as you are implanting your valve. You don't want to have a deep implant or a very high implant. It depends on the anatomy. Sometimes you want to go a little bit deeper if you have a lower coronary takeoff, but in principle, you need to leverage also, and you need to balance the risk for pacemakers with deeper implants with then also the risk for coronary obstruction. In principle, once the coronary ostia are 10 millimeters or higher, not much of a problem. If it's lower, that's where you have to think about that particular issue. I think we are all familiar with the latest generation valves. They all have a sealing fabric on the outside. This sealing fabric is meant to reduce the issue of paravalvular leaks, but at the same time, especially if there is not enough space, the sealing fabric will also affect your ability to re-enter the coronaries. An important aspect of contemporary TAVI is commissural alignment, and I'm not going to dwell too much on that. Fadi is going to discuss that in more detail, but it is an aspect that we need to master, and it's different for each valve platform that you're using. But let me get one step back and discuss the valve to coronary distance. And this basically is an important assessment that is very easy to measure by CT scan. And it is nothing else than the distance between the valve that you're going to implant, the frame, and then the takeoff of the coronary. If that is less than 3 millimeters, there is a high risk for coronary obstruction, so of immediate issues. If it's between 3 and 6, it's an intermediate risk. If it's more than 6, low risk of coronary obstruction. I think the wider the sinuses again, the easier it will become to re-enter the coronaries and the lower the risk of coronary obstruction. And that brings me to the last topic, and that is what Fadi is going to discuss. That is commissural alignment. And I think when you use these devices, you really have to understand how you commissurally align these platforms, because it's very clear that if the commissure is right in front, if the post is right in front of the coronary, whatever you will do, it's going to be very difficult to re-access the coronary, and you will end up with suboptimal engagement. It becomes very difficult to align your guiding systems with the coronary ostia. So there are several references that you can use, and they're different from an evolute valve as compared to an accurate valve as compared to Navitor. For the time being, I'm not so very concerned with balloon expandable valves, and if you ask me, the simplest way of commissural alignment can be achieved with the accurate valve, but I think that Fadi is going to dive into that.
But Nicolas, great. But before we go further on the commissural alignment, maybe there's a couple of questions, and maybe also from the panelists, it would be great. But you talk about valve to coronary distance. But of course, if you have a native anatomy of your patients, then it's based on some kind of assumption or simulation, yes, because there's no valve in there yet. So what real value do you take home as a red flag? Is it low coronary? Can you take some cutoffs, or what rules of thumb do you use for coronary height, sinus of Valsalva, STJ? What makes you a concern? What if you see something on a CT where there's no valve in yet, native patients? What is a red flag?
Yeah, so relatively red flags are, for me, a coronary takeoff of below 10 millimeters. That is sometimes of a concern, but the concern fades out if the sinuses are very wide. Then I don't really care anymore about the height of the coronary.
Well, it's not so much for coronary obstruction, but for coronary accessibility, it might still be more difficult because that's the difference. Yes,
yes.
Many people.
Yes, and that is also the interplay of the sinotubular junction. Yeah. And the sinus of Valsalva per se. So if the sinotubular junction is also, in terms of dimensions, wide enough, you can even go on the outside. Exactly. And then approach the coronaries. So it's always an holistic approach. But what I feel helps very much is that you as an operator are able to do your CT analyses yourself. I don't outsource my CT evaluations. I do them myself, because that really helps me to appreciate all the potential issues that I can encounter. But from the get-go, I take into consideration I may need to re-access the coronaries at one point.
Maybe before we continue, please interact. If you have any comments, I'm very happy to throw this microphone, and please, if you have questions,
any question is welcome.
Please interact. Maybe I have one question. I'll start with this.
What at me?
Okay. Nicolas, I think what we have to focus on as interventionalists is the patient is there. There are factors that cannot be modified, right? The patient's anatomy is there. The only decision we can make is, do we do TAVI or not? If we decide to do TAVI, you have highlighted 3 very important factors that can be modified, which is device selection, implantation depth, and commissural alignment. Fadi will outline commissural alignment. Let us discuss implantation depth. Contemporary TAVI is high implantation, right? And how do you reconcile this? Because I think most operators, we have this CAS overlap technique for self-expanding devices, even for some balloon expandable devices, and we aim to be higher in order to reduce pacemaker rates. But on the other hand, we need to observe coronary access. How do you reconcile this?
Well, I must say that I'm not a proponent of the very high implants. I don't like a 0 millimeter implant, so that you really land on the annulus itself. So in my opinion, you always need to go across the annulus. Because we not only think about coronary access, we also, if we think the broader picture of lifetime management, it's also revalving. And the higher you position your valve, the more you will also get in trouble with this neo-LVOT, neo-skirt concept. And obviously, my good friend Giuseppe had a very nice overview paper in Neurointervention 2 years ago, where it really becomes visual what happens if you implant these devices very high. So I am more for a standardized approach. Basically, I will aim for 2 to 3 millimeters under the annulus. But from time to time, especially when there are relatively low takeoffs, I might leverage and I might change and go for a little bit of a deeper implant.
But may I throw a question maybe also? Yeah, Giuseppe, yeah.
Please.
Ladies first.
Yeah, so thank you very much. Maybe we can also take our cases into consideration. So in the case I demonstrated, there was a deep implantation depth, there was a wide sinus, and I also checked for commissural alignment, so on the NGU in the movie. So what do you think about the reasons that led to these difficulties in terms of coronary reaccess?
Yeah. So make no mistake.
I don't know it. So
well, you know, there is first of all the orientation of the aorta. If it's more horizontal or if it's more vertical, that might affect your ability to re-engage. But make no mistake, it's better to have no frame in front of the coronaries than to have a frame in front of the coronaries. So just the presence of the frame, the need to re-engage through struts might makes things difficult. Sometimes, if you are lucky and you have a wider sinotubular junction, then basically you can avoid the complexity by trying to pass outside of the frame higher up. And that might then help you with coronary access. And from time to time, that also requires maybe a little bit different guiding selection, the shape of your guiding catheter. So I've done PCIs to a left main with a EMA catheter, just because I had to go outside of the frame, and then because of the frame, once you are outside of the frame, you also no longer can maneuver your guiding catheter properly. So it becomes impossible to get a JL4 or JL3 or 3.5 or an extra backup catheter in. And then
we get the iPad maybe also on. We want to, Arif want to make a point. But I think we talk a lot here about implant depth, etc. That's definitely an important point. But also going even to your initial TAVI type size, not size, but the choice of your type of the valve. And you mentioned it's important that you have indeed as little as possible mace, nitinol mace there in front. Can you comment on that between the different platforms, for example, Accurate or Evolut, how these compare?
Well, obviously, you want to have the bigger the cells, the better. I mean, smaller cells may make it more difficult. And if we look at device iterations, for instance, of the Medtronic family, these cells are becoming larger and larger. And obviously, if you compare that to, for instance, the Accurate valve, the cells are very large, and that is no longer an issue to deal with. And
you also implant that valve typically at a nominal implant depth. It's not a lot to impact there as an implanter, that you're going to say, I'm going to implant high, low on purpose. I don't think you can do that.
It becomes more reproducible.
Yeah. Exactly.
Well, I think Giuseppe has one comment, and then
very short
the
comment.
auditorium. Yeah.
So actually, to try to summarize for the audience, if someone, think what is the most important factor in terms of coronary, impairments, I think is the width of ascending aorta. Because if the width of ascending aorta is wide, actually you can go, deep in the ventricle, you can stay up with the valve, you can choose a tall or short frame. Actually, you will get the coronary cannulation. This is a very important point to share with all of you. Second point is that we don't talk during this meeting about the fact, for instance, when you have a bicuspid valve. When you have a bicuspid valve, we suggest to go for a very high implantation. And when you have the type 1, you have a displacement of the prosthesis towards one side. And actually, at that point, you will have an increased risk of sinus sequestration towards one side against the others. And actually, when we talk about coronary, we talk about tricuspid. With bicuspid valve, this problem might be even worse for the reason that I'm telling you, because you go up and displace the valve towards one of the two coronaries. So a lot of things to know in the
True, that's to investigate. But on the other hand, bicuspid valves typically have quite often a larger aortic root. So we have some data on that. Yeah, they're shifting, but we have some post-CTs there. We're investigating that. That's going to be interesting what that shows.
Or
But,
maybe one
we
comment
have
from
the
the
iPad
auditorium.
on, if we can. And there's a question.
Yes, there's one question.
Do you use the S-curve or the isolated left cusp or right cusp when you're cannulating if you have the CT?
Yeah, I do. Personally, I do. It's very good. That's information you can get out of your CT. You can, and easily, the best is to isolate the cusp you want to cannulate. For example, left main, if you want to cannulate that, I'm definitely going to go in an LAO cranial. You can even be very precise and go into the patient. If you have the patient's CT, you can do a right non-cusp overlap view. So you isolate the left coronary cusp on the left-hand side. That's typically in the LAO cranial. And then it's much easier. You know exactly your left main you can expect on the right-hand side of your screen. Yes, for the RCA, the same. That's going to be more extreme angles, typically, either an extreme REO or LAO. But indeed, these tools you can use to make your life easier to cannulate these coronaries. Yeah, absolutely.
But that said, it would not be my first strategy. My first strategy is to stay in my comfort zone, and that is just to go to LAO and then see what I recognize, right? We are all very familiar with cannulating the right and left coronary in an LAO projection. These more exotic projections that are derived from CT, I think they make a lot of sense in terms of commissural alignment. So if I would fail, then I would revert to that. That would be my approach.
Can we get the iPad on?
Yeah, if we can just get the iPad on. I just want to mention a quick thing. I mean, what we're worried about is 3 a.m. in the morning, it's a STEMI. So just to make this a bit interactive, right radial, left radial, femoral. Patients on the table. Hands up for how many of you would go right radial access? How many would go left radial? And how many would go femoral? Okay.
Well, honestly, I have a right radial approach in all my native coronary cases. In TAVI, it depends on the size of the ascending aorta. If it's a small aorta, then your maneuverability through a radial approach is very limited, especially with a right radial. So then I would prefer at 3 a.m. in the morning, I want to get back to my bed, so I would go for a femoral.
And I think this highlights a very important point. We're talking about catheters and valve frames, but actually starting from the basics. So you can tailor your strategy a little bit. So think about the access, think about the fluoro. We can get into more detail later on, analyze whether the valve is aligned or misaligned. Do I have a big post in front of my coronary? And there is a very quick way you can do this. So we're not delaying, let's say, reperfusion time. So there are some strategies that we can use in the lab within 5 to 10 seconds. I would personally say, if you've got an evolute, start with a pigtail. Take an aortogram. If it's not a STEMI, let's say it's an NSTEMI or chronic stable angina, take a pigtail, fully understand the problem that you have, and then go from there.
Maybe one question, very good points. I would like to know from the audience, is this what we are talking about? Is this relevant to you? So we have seen 2 very impressive nightmare cases. Who in the audience had similar experience? Please raise your hands. Okay, at least some of you, okay.
And then keep on practicing. Because
yeah.
and you know, as we are doing more and more TAVI, and patients after TAVI will get older and older and, you know, will outlive their devices, we all will get confronted with these moments where you need to re-engage the coronaries after a TAVI procedure. And I would definitely encourage, if this patient is announced to you at 3 a.m. in the morning, and if you have the ability to look at a CT scan, the original CT scan, that will really help you out.
Great. Thank you. I think we have to move on for the sake of time, and Fadi is going to talk about commissural alignment. Just before we do that, who is doing TAVI with attention to commissural alignment? Who does that? Quite some. Okay. That's good to know. So Fadi, tell us what are potential advantages, techniques, what is the difference between platforms?
Yeah, we're not going to discuss step by step each platform because there's a lot of sessions, but we just want to talk about the impact on coronary accessibility. So when I think about commissural alignment, I want to think why is it important? One, because coronary access is difficult sometimes and taller THV, so coronary access is important. Two, it reduces the risk of coronary obstruction when we're doing TAV-in-TAV or TAV-in-TAV. It will increase the likelihood of redo TAVR by reducing the risk of sinus sequestration, like the case of Francesca. And it also, data from Ole about the impact on durability. It turns out that if you're commissurally aligned, will show some data, it might affect probably durability. And if we want to do TAV-in-TAV and you have the post in front of your coronary, you cannot do leaflet modification. Like you cannot do basilica if you have risk of coronary obstruction. So we talk about commissural alignment, but we have to define it. What does commissural alignment or misalignment mean? So if you look at the slide, we want to be away from the coronary. This is how a surgeon will implant his valve. So we have mild, moderate, no commissural misalignment, and severe commissural misalignment. Severe commissural misalignment, you have the post in front of the coronary, and this is what you don't want. If we want to look at each platform, if you want to identify the commissure with the Evolut, you see it's at the C paddle. For the Accurate Neo 2, you have two landmarks. You have the post and you have the freestand strut. And for the Portico or Navitor, you also have the post. So this is how you identify them also on fluoroscopy. So if we take an Accurate, the two things we're going to focus on are this free strut and this post. And you want to go to your cusp overlap view, and this is what you want to see. You want to see one post to the right side of the screen and a free strut, and this is how you know you're going to be commissurally aligned. And this is extremely important. If you go to your three-cusp view, you're going to see three posts parallel to each other, but you also always want to look at it in the cusp overlap view. So if we look at the COM-ALIGN study, this was a commissural alignment study. They took 60 patients, 20 with Evolut, 20 with Accurate Neo 2, and 20 with Portico. And what the result of the study showed that with the Accurate Neo, you had 100% avoidment of moderate to severe misalignment. So you did not have any problem with severe misalignment. For Evolut Pro or the R, there was 10% of cases had misalignment. And with the Portico, you had around 25% had severe misalignment. So even with these techniques and even with seeing these struts and seeing the post, sometimes you cannot do it 100% with the other platforms. And the Neo-Align study as well, there was 170 patients and 97% of the cases had no significant misalignment. So with the Accurate Neo platform, you have a high success rate of getting full commissural alignment. And this is a study that is very important by Giuseppe. And if you look at the cases where you are not aligned, I'm gonna go one here. This is what's important. With the short frame with the SAPIEN 3, you had very high success of selective cannulation. Okay, that's very important. And if you look at this slide here, non-aligned versus aligned. And the aligned, you had the higher chance of selectively cannulating your coronary. And the non-aligned, your rate goes down to 40%. So this is why we should aim for commissural alignment. It will make your life easier when you come back for an ACS and try to cannulate and get better support when you want to do an angioplasty. Now, we're going to talk about outcome. Why is commissurally alignment? In the Edwards platform, you cannot do commissural alignment. You cannot check for it. And in this study published last year, it showed that around 50% of the cases you had severe misalignment. And what was striking in the cases that were misaligned, you had high risk of regurgitation and you had significant increase in your gradient. So this is the first sign that you might have higher gradient when you're misaligned. And this is data that was presented recently. And you had 900, this is a COM-ALIGN Neo 2, 900 patient, fluoroscopically based commissural alignment. And they were followed, they had their gradient followed and the rate of PVL. And if you look at some slide of the study that were striking, there was a higher risk of severe patient-prosthesis mismatch and the patient with severe commissural misalignment, okay, compared to the patient who had no commissural non-alignment. And samely, you had the higher risk of more than mild PVL. So this is two hard outcomes showing that if you have severe misalignment, you have higher PPM and you have higher PVL. So if I looked at the importance of commissural alignment, just to summarize it, you have better coronary filling, you have less leak, less PVL, it's easier to do a redo TAVR, you have less stress on the leaflet and less risk of halt, and you have easier coronary access. Thank you.
Thank you, Freddy. So, Giuseppe, if you have the choice between a platform where you can easily do commissural alignment with or not, does this impact your choice for specific patients where you're gonna go for one or the other valve to implant?
Repeat the question, please.
Yeah, if you have the choice between a platform where you can easily do it with commissural alignment, obtain it with or not, does this has an impact on which patients? Does it have an impact on which valve you're gonna choose?
So actually, I think the valve orientation should be mandatory. For me, it's the default strategy. We cannot discuss in elective case to not go for orientation of the valve. Unless you stay in cardiogenic shock or in severe hemodynamic decay, you don't have time, you need to save the patients. So the patient first, but actually when you decide to select a valve, you need to think the whole sequence in that patient. Because this is an elective patient, is not time dependent, so you have time to breathe, relax, and think twice what you have to do in this patient. So for me, the default strategy is to orientate, and for sure, not all the self-expandable valves are the same. There are some, like the accurate Neo, in this case, that is easily orientable. There are others that do not have market beads. It's a little bit more difficult and tricky. You need to go with close-up, what are things to orientate. But for me, it's very important because this is mainly grounded in the surgical science is like that. They don't have any valve that is not oriented. So I don't understand why we should go for a non-oriented valve.
So, Fadi, what determines the fact that you can easily get commissural alignment with, for example, accurate? What does it make that it's easy to get commissural alignment?
With the accurate?
Yeah.
One, because you have your landmark, and two, you can rotate it easier.
You mean you see clearly where the
clearly
post?
where your post and your free cell, you have two markers for me to look at it, and then it's easily torquable.
Yeah.
So if you look at the Navitor, you see the post, but it's not as easy on fluoroscopy to be, it takes more precision to be able to do it.
I agree. These two factors are determining. Yes,
and the Evolute, for example, with at least with the Pro Plus, with the two spine, it's more difficult to torque it when if you go at 3 o'clock from the beginning and you're still not aligned, it's difficult to torque it.
Very briefly, so actually when you go for the orientation, you don't have all the time in the world, because if you try to change the trajectory 3-4 times, at some point you will see that there is an hemodynamic decay of the patient. So having a valve that is easy to use in this regard is very important. You cannot stay there 10 minutes to try to orientate the valve, because there is also an increased risk of stroke. So you cannot manipulate too much there.
No,
maybe I can comment on that. We have done a lot of cases now. There was a learning curve. In the beginning of using commissural alignment, it took around 10 minutes. And it was a pain. And now it takes 20 seconds, I think. And sometimes my second operator is much faster. I have to think about which orientation was it, and they already start, okay, and I say it's okay. And maybe as an anecdote, we have been doing commissural TAVI for 20 years, right? And we have started doing commissural alignment the last 2 or 3 years. And as an anecdote, you may know Thomas Walter. 12 or 13 years ago, he promoted commissural alignment with the transapical accurate system. And he said, you can do it. But I think at that time, no one was really interested. And now it's really a hot topic. And I think to underline, I think if you can do commissural alignment, you should do it. And our experience is you will have 99% success, and data shown here shows it's safe. And I don't think we need to achieve perfect commissural alignment, but the first goal should be to avoid complete misalignment.
Yeah, exactly. I think that too. There's coming more data on that indeed severe commissural misalignment, that's the thing you want to avoid, where the first for coronary accessibility, but even for valve performance, that's the only thing you have to avoid. If you have even mild or even maybe moderate commissural misalignment, that's maybe less important. So at least for sure for the accurate platform. Okay, I think thanks Mahdi, we have to move on and we go to Arif. Arif has tremendous experience with the bench test work. Had the pleasure to work with him on that. And then I think you did a lot of coronary accessibility tests. So please share your experience with that.
Great, thanks, Ollie. So it's a pleasure to talk to you about coronary access and some of what we've learned. I'll focus, we've discussed about the Evolute valve. We know the Sapiens is short frame, so I'll focus this predominantly on the accurate Neo valve. First of all, a lot of the principles, challenges, techniques apply across the spectrum of TAVI procedures that you do with this particular valve. And you can see that that's essentially because you maintain the valve geometry independent of whichever valvular complex that you have. Now, for us, it's obviously impossible to go inside of patients with multiple different catheters, multiple different TAVI combinations. So we really use this kind of patient-specific pulsatile flow simulator approach, whereby we can take any patient, make the anatomy, take any combination of valves that we want, and then just play, essentially, inside with different catheters. So with this methodology, I'm going to share with you some insights. We've already touched upon what some of the challenges and problems that we can have across, again, the spectrum of TAVI procedures. So we've got posts, leaflets, leaflet overhang, and these are all the obstacles and the barriers that our catheters face. And so essentially, I want to give you a slightly different way of thinking about these things, because essentially it's just a geometrical problem. A lot of our barriers are centrally located. All of the problems that we have are in the middle portion. If we were to take a conventional cannulation approach, like we've all been taught, of bringing the catheters down through the middle, rotating to the sides, we'd be much more likely to engage all the obstacles and all the problems that we have. So instead of coming down through the middle, particularly with this valve frame, what we want to do is deflect our catheters to the sides earlier and higher up, inner curve, outer curve. Then, we mentioned the sinotubular junction. It really is the bottleneck for coronary access. You need to be able to cross the sinotubular junction, but then you also need enough space to be able to rotate your catheters. So sticking with that approach, I'm going to present to you 3 different techniques and then a couple of other concepts. So this is the inner curve approach. Here, this is a native TAVI. We've got a catheter which is coming down, which is essentially a long catheter, short tip, specifically a Judkins left 6 catheter. And it comes down with a vertical approach under the sinotubular junction to achieve the cannulation. Here we've got a valve-in-valve TAVI setting. Once again, same concept. We've got an oversized Judkins left 6 catheter. The catheter comes down, pull the wire back, closes the Judkins shape, and you can drop down and enter into the sinus.
Arif, can you go a bit deeper in that? Because that's something new concept for most. We experienced this in the bench. So, but that taking an oversized Judkins, what does it give of? It's for the support. It's for the angle how you arrive. What?
Yeah. So I'll come on to that. So this is a final example of a very challenging situation. Redo TAVI, and once again, same concept. Oversized Judkins left 6. Coming down and entering. And exactly like Ollie's question, like many of you might be asking, I've never used a JL6. In fact, show of hands, who's ever used a JL6 catheter in the cath lab? Next question will really be, who actually has a JL6 catheter in the cath lab? I can tell you that I even wouldn't know where to find one in my own cath lab. But the question is why? Why JL6? So we know, conventionally, we upsize JL3, 4, 5, 6 as the aorta gets more dilated. You have a patient with an aortopathy on the table, the fellow's nose, go with a 4 or 5 to begin with. And that's because of the difference between the primary and the secondary curve. The longer the distance, you use it for a wider aorta. Here it's different. To answer your question, we're using the difference between the primary and the secondary curve for the vertical sense, to allow you to simply drop the catheter in a very vertical way, avoid the central obstacles, and it allows you to come along the inner curve. So that's the JL6 or the inner curve technique. Similarly, for the right coronary artery, you can adopt an outer curve technique. So here you're simply directing your catheter along the outer curve. Then you've got the gap, the sinotubular junction, using a short, narrow tip catheter, drop down into the gap and rotate into position. Now, particularly the catheter that's used here is an internal mammary catheter. And I think someone mentioned earlier about using a mammary catheter as an example, exactly. So why the mammary versus the Judkins Right 4? Well, the mammary has a narrower turning radius. So it means that if you're in a tight space and you've got a small gap between the aorta and the valve complex, you can rotate much more easily into position. And that's one of the advantages of using the mammary. Next, I want to talk about the lateral approach. This is something that's a little bit unique with the Accurate Neo platform. This is actually a live case that was demonstrated last year at London Valves. We took the patient's anatomy, went into the lab, and simulated the coronary access. What I want to highlight is you can see here, fluoroscopically, you can't see a difference between the two approaches. When you look inside, one is clearly through the valve frame, and one is kind of external, coming round from the side. And this is something that time and time again can be quite useful in this setting. So this is a redo TAV, high neoskirt situation, you can't access. But if you simply go laterally, you can use the open cells of the Neo's arch to drop into an adjacent sinus and essentially circumnavigate your way around the assembled valve complex in what is a lateral approach. Even in this setting, this is a very challenging. We've got two tall frame valves, two self-expanding valve platforms, so many barriers here in the middle, but you can simply navigate around using different catheters. And just to end now, again, coronary access, we talk about which catheters, which techniques, but I think we can take a step back, and someone mentioned earlier about fluoroscopy. I think it can be quite useful if you've got time to evaluate the problem, evaluate the challenges you have in front of you. What's my aorta like? How high are my coronary arteries? How much space do I have? Or with a quick pigtail injection. Then particularly Fadi talked about commissural alignment with the posts and things. You can even understand if it's a left coronary you're targeting, is my valve aligned? Yes or no? Then I think when you're doing the coronary access, you can use the C-arm, so you can adopt an LAO angle, which will allow you to open up the aortic arch, and then you can gain access to the inner and the outer curves. And then Ollie, as you mentioned earlier, we can really isolate the cusp or the coronary that we want to go into. Of course, this is all time permitting. And finally, I think we should not ignore the access site that we go to, because certainly if you go femoral, much more easy to access the inner and the outer curves, and it can be much more easier, particularly in smaller routes, than a right radial approach. So I think 5 sort of take-home messages, sort of really bringing it down to practical things to share with you all. Think about your access. If you have time, you can evaluate the valve challenges that you have in front of you. Use your C-arm and fluoro to see how you can help. Then think about the technique, inner curve, outer curve, lateral. We can be creative with the catheters we use. I have to say, we found the JL6 is very reproducible, very reliable, even for non-expert operators. And finally, I'd just like to end, this is in this sort of interactive spirit. We have now developed a TAVI Access focus group, and we really want to learn from the community. We want to learn from all of you. So if you have challenging cases, difficult cannulations, things that you've learned, catheters that you've tried, because right now I think all of us, N=1, N=2, but really we need to collate all this information. So do email us, taviaccess@gmail.com, and I think we can all learn together. Thank you.
Maybe some comments there about the techniques used. Do you think this is valve specific, or is it, what do you think?
For me, I think that everything is reasonable on top of the fact that you have a wide ascending aorta. If you have a wide ascending aorta, you can do all these things, all these maneuver. If you don't have a wide ascending aorta, you can do anything. So this is the most important part. We have to admit that. Otherwise, it might be, misleading also for the people. The anatomy, the non-modifiable factor, that is the catchphrase of today, by means of Nicholas, is very important to share with all of you. So the point is we need to be very thoughtful in the choice of the first valve, based mainly, at least to me, when we think at the coronary to this factor. Then there are many other things, small annuli, many other variables to consider. But this is an important point, I think.
Arif, you want to react on that?
Yeah, I think that's a fair point, but I would slightly challenge that in the setting that we've actually taken patient anatomies with very narrow STJs, very narrow aortic roots. And the advantages of using this JL6 and mammary approach is that you don't have to rotate so much. So when you get into a narrow aortic root, the problem is you don't have space to rotate. So if you can use a catheter which doesn't require rotation, then you can at least enter into the sinuses. And I think the mammary is a perfect example of that.
I think a point in favor of this valve, I think is important also this point to share with the audience, is that as you nicely have shown that you can get into the coronary artery from outside of the struts, but considering that in this valve, the leaflets do not hit the struts, so it's not possible to tilt up completely the leaflets. You have an extra space from the maximum excursion of the leaflets and the struts. So you can get through the coronary outside of the leaflets or outside of the struts. This is an important point because this is not true for all the self-expandable valves.
Okay, I think we really have to move on because we have 9 minutes left. So Giuseppe, you can talk about the topic of implications of future TAV-in-TAV on coronary access. So now we make it a level more difficult. Now it's not only coronary access and accessibility in one single TAVI in place, but what if we have to think of a scenario of TAV-in-TAV? Yes, Giuseppe?
Thank you. So implication, future TAV-in-TAV and coronary access. So let's get started from this, for what I consider is the guiding concept. This is the overarching principle. The first THV choice matter a lot. So the first cut remained the deepest. No story about that. And here you can see this a pathologic spacement where you can see the relationship between the struts and the coronary cannulation, the coronary access, without considering the asymmetric skirt and the leaflets. So looking at the science around these points, we have 3 different papers, 3 different groups. The first one is from Padua, then we have New York, and the last one is Ole. And here you can see pretty much consistently that a tall frame valve in 2/3 of cases may create some problem in terms of coronary access. We're talking just about coronary. We're not talking about pacemaker, gradient, patient prosthesis, etc. The focus is just coronary. On the other hand, the short frame, like the surgical valve, actually permits an easier coronary access that is impaired only in 1/3 of the cases. So, to simplify, but I think it's important to simplify our practice sometimes, we can identify 3 different types of coronary, let's say, impairment. The type 1 is when we have a short valve, like the surgical valve. You don't have anything in front of the coronary, so it's quite easy to think that when you go with a second valve, mostly if it is oriented, might be, an easy access. Second type, 2A, is that when you have a tall frame that is also oriented, but actually you have to consider that in this case, the neoskirt that you create with a second valve is maybe as tall as 33 centimeters, 30 millimeters. So what matters is the width of ascending aorta. If the VTA is large, actually, a TAV-in-TAV is feasible when we consider the coronary access. Why is so important VTA, not VTC with the TAVI? This is exactly the opposite with the TAV-in-TAV, where you consider just VTC. Why? Because the leaflets of the surgical valve do not touch the STJ. When you have a valve that touches the STJ, you don't have to consider anymore, or let's say it's not so important the VTC. What is important is the VTA, where you can create the sinus sequestration. The last point is that when the TAV-in-TAV is not feasible, because there is a concrete risk, unacceptable, let's say, risk of coronary occlusion, when you have a very narrow ascending aorta and you see clearly by angiography, by CT scan, that you don't have extra room, and when you go with the second valve, you create the sinus sequestration. Then we have different combinations to consider. It's not so easy because, among the tall valve frame, we have a valve like the Accurate with a big hole, the one in the middle, that is 2 centimeters. That is huge in terms of facilitating the coronary cannulation. There are others that have more closed cell. And actually, even though you get rid of asymmetric skirts, get rid of the leaflets, the picture on the right-hand side of the screen, you can see if you have a malapposition of the struts, it's very difficult even to get through with a 6 French catheter, just because you have a misalignment of the cells without considering leaflets and the skirt and so forth. So there are different manuals. clearly I show this because I have a clear conflict of interest with this paper, but actually the point is, for me, it's useful because you can download this checklist. You can download this from this paper, you can apply in the everyday practice of the lab where you can collect in a standardized way what all is needed for the final valve choice and sizing and positioning of the valve. So actually it seems very easy, but it's not complex at all, because there are 4 main chapters. One is the CT scan evaluation before the first TAVI. We have seen the cases. Second point is to know exactly what is the first valve, the index THV matrix. So when you say accurate 25, you need to know the metric of this valve, the inflow and the outflow. You need to know the neoskirt that you create. You need to know everything of this valve. Then you have to know the mechanism of failure that is remarkable. And finally, you need to review the CT scan of the first THV. Let's make 2 examples and then I've finished. SAPIEN inaccurate and vice versa. These are the most important points to consider. VTA, I explained you why, not the VTC. The neoskirt height with accurate might be 30 millimeters. The coronary height and the implantation depth, as Nicholas showed you before. So based on that, when you go with the SAPIEN inaccurate, everything is depending on the mechanism of failure. If you have a stenotic mechanism, you need to tilt up completely, you need to smash the leaflets, because you cannot leave any residual gradients. So you need to go very high at the level of the commissure, the top part of the accurate, and the risk there is to create some problem in terms of coronary cannulation unless you have a roomy VTA that is at least 2 millimeters. When you have a regurgitation, you may avoid, you can skip this risk because you can go a little bit deeper, accepting a little overhanging of the first leaflets without any risk of coronary occlusion, and it is possible to cannulate the coronary by means of the orientation of the first valve. The opposite, accurate in SAPIEN, then I've finished. Again, the same 4 parameters, VTA, neoskirt, coronary height, implantation depth. What is the optimal position? This is the discussion to do in this case, because the valve is a short frame, the SAPIEN. The recommendation from the bench test is to stay maximum 2 or 3 millimeters above the SAPIEN. Why 2 or 3? Because if you stay 5 to 6, actually you have a billowing of the leaflets in the SAPIEN, and you don't have a clear flip up of the leaflets. So you need to stay maximum at this level to permit that the hooks of the accurate to stay above and to smash completely the leaflets of the SAPIEN valve. So, and actually, this is mandatory again, when you go with the accurate in SAPIEN to orientate the accurate. This should be a default strategy in case of third intervention.
Giuseppe, what's the risk if you go too low or too high? Yeah, can you tell that? If you go too low when you're accurate in your SAPIEN, what's the risk there?
Yes, can I go back?
Can we go back? No.
Okay, what is the risk of, if you go too low, this is pretty much the same with the bicuspid valve. If you stay too low, you have a restriction that is created by the struts of the Edwards, pretty much like the Raffi in the bicuspid valve, and because of the hook, you cannot expand the accurate. This might be one problem. So you need to stay above with the hooks compared to the top row of the Edwards, and you don't have to stay too high, otherwise it's very difficult to tilt up completely and smash the leaflets of the SAPIEN that stay before in. If you have any other comments, you can add something.
No, I would think, one has most experience with putting accurate in a SAPIEN, I think, or in a surgical valve for sure. I would think the risk if you put it too low, then the upper crown is sitting into the SAPIEN stent frame, you will have bad hemodynamics for sure, yeah. I think. And if I would even be scared placing it at 3 millimeters upper crown, 3 millimeters above the SAPIEN. I think you can come away with it, but if it go higher, you may have a real risk of pop-up.
But it's not just a pop-up. It's also because you need to grab completely the leaflets.
The leaflets of the SAPIEN.
Yes, because otherwise you just pinch the tip of the leaflets, like, the mitral clip is not the way to go.
Yeah. No, perfect. Great. I think One, you're going to conclude the session with some take-home messages.
Yeah, I think time is up. Everybody's tired, and I have the pleasure to wrap up the session. Thanks to Boston Scientific for making this possible. I think it was a very interesting interaction with very distinguished panelists and speakers. Thank you for your contributions. I think time is up. So the main takeaway is that we need to take future coronary access into account, especially when we think of modifiable factors like valve selection, implantation depth, and commissural alignment. And I think it's important for you, if commissural alignment is possible, I would really go for it. And I think we should not forget the highest goal is always procedural success in all of these. And I want to challenge you, if you anticipate similar outcomes with 2 different valve platforms, and then you ask yourself, if you get the valve implanted, would you choose the one with easy? We are talking about high success rates when we talk about 95% coronary accessibility. I think this is good in terms of device success, but please keep in mind, in native anatomies, the success rate of coronary cannulation must be 99 or even 100%. So this should be taken into account. We discussed very interesting contemporary practice is to have a high implantation position in order to mitigate conduction disturbances, but this may, on the other hand, compromise future coronary access and future TAV-in-TAV procedures. So I hope that you enjoyed this session, and I wish you an interesting further conference. Thank you very much.
Great.